Thank you for standing by. Welcome to the Industry Perspectives on Healthcare IT and the Economic Stimulus Package conference call. During the presentation, all participants will be in a listen-only mode. Afterwards, we will conduct a question and answer session. At that time, if you have a question, we ask you to please press the 1 followed by the 4 on your telephone. Should you require an assistance at any time during the presentation, please press *0. I would like to remind you today's call is being recorded Thursday, March 26, 2009. And now I have the pleasure to introduce Mr. Mark Siegel, Director, Government and Industry Affairs for GE Healthcare. Please proceed, sir.
Thank you, Fadi, very much. Good afternoon. I'll be your host today for this first webinar in a new series from GE focusing on the recently passed $30+ billion healthcare IT stimulus package and what it means to provider organizations. The healthcare IT portion of the broader stimulus package that was signed in last month is known as the HITECH Act. Today's session will focus on industry perspectives on healthcare IT and the economic stimulus package. Sorry, I'm having a slight technical problem here. Well, we've got a very timely and interesting program today and a terrific panel of speakers. Our first panelist is Stephen Gorman from GE Healthcare. Stephen is the Global Strategy Officer for GE Healthcare Information Technology, and Dr. John Halamka from Beth Israel Deaconess Medical Center in Boston. Rachel is Executive Director of the New York eHealth Collaborative, a statewide multi-stakeholder organization committed to advancing health information technology adoption and use in New York. In addition to his role as CIO at Beth Israel, John is also CIO of Harvard Medical School, Chair of the New England Health Electronic Data Interchange Network, CEO of MassShare, a regional health information organization, and Chair of the Healthcare Information Technology Standards Panel. Finally, John is also a practicing emergency physician. I'd like to welcome our speakers and all of you to today's session. And the obligatory disclaimer. As I mentioned earlier, our topic today is the Healthcare Economic Stimulus Package. I'll provide you an analysis of this important new legislation and its many implications for healthcare providers. We will also review the latest developments in standards and certification requirements that are needed to take advantage of the EHR incentives created by this legislation. And we will seek to provide insights that will allow you to analyze the implications of HITECH for your own organization. Clearly, these new developments and associated funding opportunities emphasize the powerful role that healthcare IT will play in the future of quality healthcare delivery and financial performance. For today's session, Stephen will begin with an overview of the stimulus package, and then he will address the Medicare and Medicaid incentives contained in that package. Following Stephen, Rachel Block will address implementation from a state perspective, including how Medicaid funds will flow from the states and how state funds are able to be used. We will conclude with John Halamka, who will review standards and certification issues that will drive how this new program is implemented. One of our goals today is to allow you the opportunity to ask questions directly to these industry experts. So the second half of the program will be an interactive Q&A session. I encourage you to submit your questions in advance using the EMR@ge.com email address that you can see on your screen. And as well, the operator will also open up the line for live questions. So with that, I'm going to turn the session over to Stephen Gorman, Global Strategy Officer for GE Healthcare Information Technology. Stephen?
Great. Thanks, Mark, and good afternoon, everyone. What I'm going to do to start out is actually just walk through the financial aspect of this, talk a little bit about exactly how the money is going to flow. Before I get into the specifics of the dollars, I wanted to step back for a second and just provide some context on the stimulus package and talk a little bit about what the administration in Washington and Congress was attempting to achieve as a result of including this in the stimulus package. Mark, if you could move to the next slide. There really are two critical things that the government was intending to do. One, clearly, was to stimulate the economy. There is clearly an intent here as a result of the billions of dollars that are going to be spent on healthcare IT to create jobs not only for the technology companies that are going to be building and implementing the software, but also to create jobs within the healthcare organizations as it relates to implementing and maintaining those applications within there's a key focus on stimulating the economy, on creating jobs, and from a political perspective, these are the right types of jobs to try to create. These are high-tech jobs, these are clean jobs, these are jobs that are focused on healthcare, and again, from a political standpoint, this is a nice place to direct money. The second thing that the administration was clearly trying to do is to make sure that if they're going to spend $30 billion of taxpayer money, $30 billion of all of our money that are on the phone here today, they also wanted to make sure that ultimately this was going to do some good for the country. As I think everybody on this phone is aware, the U.S. healthcare system is the most expensive healthcare system in the world. Year over year, we're seeing very significant increases in the cost of healthcare, and we're at the point where most experts believe that it's becoming unmanageable in terms of the cost. I don't believe that there is anything close to agreement on how to control costs at the highest level, but there does appear to be a general belief and a general understanding that whatever mechanism, whatever approach may be used to help control the increase in healthcare costs, it is believed that information technology is a component of whatever that solution is. So clearly the second goal of having this program be part of the broader economic stimulus package was to make sure that on the hospital side as well as on the physician side that there was money allocated to establish the healthcare information technology infrastructure that would allow the organization to ultimately achieve some of the benefits that IT has provided to other industries. So there really are two aspects to what the government was intending to achieve with this legislation, and I think keeping those. So with that, let's talk about the numbers. You know, there's been a lot of very large numbers that have been thrown around as it relates to the stimulus package, but specifically relative to healthcare IT, the government is actually projecting that they're going to spend $30 billion, that they're going to provide $30 billion of increased reimbursement to physician groups and hospitals that are meaningful users of electronic health records over this next several years. They expect that Medicare and Medicaid are going to see about a $12 billion net savings as a result of having technology out there in the industry, and the difference between those two numbers is roughly the $19 or $20 billion that you see in a lot of the popular articles. But the amount of money that is actually going to flow to your organizations is this $30 billion, and to give you data that the entire size of the healthcare IT industry today on an annual basis is about $15 billion. So we're talking about a very, very significant amount of money. And the key objective that the administration had set out, that President Obama had set out, is to have everyone in the U.S. using an electronic health record by 2014. That was the real high-level aspirational goal. When the Central Budget Office, the folks inside of Washington that really crunched the numbers, went through this, they came up with a slightly less level of adoption, but still clearly something that was very, very ambitious, and they're projecting about 90% of the physician groups and 70% of the hospitals would be utilizing an electronic health record by 2019. So that's clearly what the administration is shooting for. And the other important thing related to the system is they wanted to make sure that there was the right level of oversight and control for these billions of dollars that were going to be spent. And what they ended up doing is providing significant power and significant control to the Secretary of Health and Human Services, as well as to a position that they're calling the Office of the National Coordinator, which is a position that reports directly into the Secretary of HHS. So there is going to be quite a bit that you're going to be hearing from these two organizations over the course of the next several months and years that is going to really help clarify things. And John Halamp is going to be talking later in this program a little bit more about some of their areas of focus. If you go to the next slide, Mark. So just a quick snapshot in terms of where that money is coming from. Medicare is going to be the largest contributor. The expectation is $17 billion is going to come from Medicare. The expectation is approximately $12 billion is going to come through Medicaid money out into the system. And then there is $2 billion that has been set aside not necessarily to go directly to health systems and to medical groups for using electronic health records, but the $2 billion is to help the industry prepare for the significant injection of technology that is going to occur as a result of this act. And I want to start walking through the economics by talking about this $2 billion. So Mark, if you go to the next slide. One of the key things that was happening in Washington as this stimulus package was being put together is that there was a debate over whether the healthcare industry was ready to accept such an ambitious proposal. You know, would the industry be in a position where it was ready to exchange clinical information? Did the industry really know what it wanted when we talked about quality measures and quality reporting? And I'm not sure that the debate was ever finally settled in Washington, but what they did do is they set aside $2 billion to really help set up the infrastructure for getting the industry ready for all of this new technology. And this $2 billion is going to be distributed out into the industry largely at the discretion of the Office of the National Coordinator. The $2 billion is earmarked for several things, one of which is the creation of a national network for health information exchange. There is money that has been set aside for healthcare and IT training to make sure there are enough people trained in the industry to utilize this technology. Grants that will be available to medical groups, to hospitals, to work on and prove out some best practices as it relates to the utilization of EHRs, as well as some best practices and some pilots around quality reporting and quality measures. So this money is really earmarked to help pilot some programs that can very much serve as the benchmarks and as the framework upon which some of the refinements to the program that will come out over the years are built off of. This slide is a little bit confusing to look at, but it is probably an appropriate representation of some of the complexity that is involved in actually getting this money out to the industry. The states are clearly going to be heavily involved, as well as a series of government and private entities, and we expect there to be quite a bit of activity at the state level as it relates to competition for these dollars, and Rachel's going to be touching on some of that in her presentation. Mark, if you go to the next slide. So in terms of financial support, I want to talk really about the Medicare payments at this point. I want to talk about Medicare for two reasons. One, it's the largest amount of money, $17 billion of the $30 billion. And the second is it's the most simply defined. And basically the way the Medicare money is going to flow is that if you are a physician group that is a meaningful user of an electronic health record starting in 2011, that you will receive up to $44,000 of additional reimbursement from Medicare as a result of using that electronic health record. And it's important to note that this money is not being provided to organizations that are using an electronic health record. So if you bought an electronic medical record 5 years ago, 10 years ago, 15 years ago, as long as you are a meaningful user of an electronic health record that is a certified product, you will be eligible for this money. And the way the program works is that there's a series of incentives up front for adopting technology. And then starting in 2015, there actually will be some penalties. There will actually be some reductions in your Medicare payments if you are not a meaningful user of an electronic health record. So there's a kind of a balance here of trying to incent folks to move up front with some penalties at the outer years. And from a hospital standpoint, the equation for how they arrive at the dollars is a little bit more complex, but we're talking about roughly payments per hospital for organizations that are up on a electronic health record. This number could be adjusted up or down based on the Medicare share, the number of discharges, charity care, and things along that line, but it's in the ballpark of $2 million a year, and much like on the physician side, there are some reductions in Medicare reimbursement if an organization is not a meaningful user by 2015. So the other important thing to note here is that the government is very mindful about the fact that they want to make sure that organizations are utilizing electronic health records that are sophisticated in terms of their capabilities, and they also want to ensure that folks that are receiving this money are meaningful users of an electronic health record. They want to guard against the possibility of a group buying an electronic health record and never really using it in clinical practice. So John is going to be talking later about some of the ways in which these items are going to be more clearly defined going forward, but the law contemplated some broad general categories when they thought about this notion of a meaningful user of an electronic health record. And they contemplated things like having the physicians utilize electronic prescribing, having the organization have the capability to provide quality reporting in terms of their performance. They contemplated having these electronic health records be connected to a health information exchange to allow caregivers to exchange information on a particular patient. So we'll be talking more about this, but it's important to know that there is an expectation that in exchange for this money, that these applications will actually be used in the care process. From a Medicaid standpoint, they are complex in terms of the mechanisms for calculating the payments, but it's important to note at a high level that there is a comparable amount of money available to medical groups and a comparable amount of money available to health systems that receive high volumes of Medicaid dollars from the government. And that the thought here was certain types of organizations that have a high Medicare population would get the money from Medicare, and organizations that didn't have a high Medicare population but had a high Medicaid population would be able to qualify for a comparable amount of money under that program, and it has the same requirements around meaningful use and certification. Mark, if you go to the next slide. So stepping back to the Medicare incentives for a moment again, because these are the most straightforward into the system. You can see the start dates in terms of the year on the left-hand column. And the way the legislation works is they're saying if a provider organization, a physician group, is up running on an EHR, that in the first year, 2011, each physician would receive differential reimbursement from Medicare of $18,000 a year. And then in 2012, it would drop to $12,000, 2013 dropped to $8,000, et cetera, so that you can see physician groups that went up in 2011 would receive a total of $44,000 of additional reimbursement per physician. The same would be true for groups that went up and were meaningful users starting in 2012. And you can see as you delay the implementation of an electronic health record, the amount of incentive that you get from the government goes down. $39,000 if he's 14, and as indicated, there are some penalties for folks that delay. So the intent here was clearly to try to encourage physician organizations to become meaningful users of electronic health records as soon as possible. With that, Mark, I want to turn it back to you.
Thanks very much, Stephen. Rachel, can you tell us what this all looks like from a state perspective?
Well, I would be happy to do that. We are really thrilled to be reviewing the proposed activities that will be funded under the stimulus bill. Recognize that there are a lot of details still to work out, but nevertheless, while clearly this represents a significant enhancement in terms of the national policy focus on these issues, it also will significantly strengthen state-level activities to promote health IT. And as you indicated in your introduction of me, the New York eHealth Collaborative is one of a number of these organizations that have emerged across the country to try to bring some of these benefits to the local level by bringing about statewide coordination. This is first slide that I have is just a slightly different way of depicting some of the same information that Steve just went over. And just to, again, summarize, you see the Medicare and Medicaid payment incentives on the top. And obviously, states will play an important role here because Medicaid is run by the states, and they will need to be administering these specific provisions. But in addition, you see health information exchange planning and development, planning grants and implementation grants. These will also go through states, as will the next category, the EHR adoption loan programs. And then as we get down to some of these other activities, while states are not specifically designated to take the lead, it is likely that states will be playing an important role either in directly administering or attempting to coordinate the responses for these various activities under their states. So states will be playing a significant role and a growing role as a result of the overall structure of the stimulus bill. If you go to the next slide. So what I'm going to do is just talk a little bit about some of the health information, Medicaid provisions, and give you a couple of pictures, literally, about how we in New York envision integrating all of these activities so that we are consistent with national standards, but also able to advance our unique statewide vision in terms of how health IT will really advance healthcare reform activities. So the health information exchange provisions haven't gotten quite as much attention as the incentives, although as you'll see in a moment, there is an important interrelationship here. And as you can see, there is a differentiation between the planning and implementation grants. And we're expecting that the implementation grants will, in fact, command the lion's share of whatever portion of funding the federal government within that $2 billion that they have the discretion to divide up will be allocating. And there are a few key aspects that the legislation is not very specific. We expect that these state plans will have to address governance structure, the technical architecture for health information exchange, how specific clinical uses will be advanced, and of course the issues around privacy and security, which are at the forefront of national and state policy discussions about this. And our observation would be that just as we think that it's important for physicians and hospitals to be implementing these systems now, not to wait for the criteria to be fleshed out, similarly, we think it's important for states to be developing this health information infrastructure now, if they haven't already started that, because first, it will allow them to draw down more of those implementation funds, but also, as you'll see in a moment, it will really to compete for those Medicare and Medicaid incentives. You go to the next slide. This provides similar information to what Steve covered, so I'm not going to go into it in a lot of detail. It is simply in a different format. But let me just make a couple of observations about the Medicaid side of the equation. First is that the federal government really gave states an enormous incentive to do this because they're essentially picking up 100% of the tab. Any of you who've worked around state Medicaid issues know that often the concern is when a new service or a eligibility category comes along, the state still has to provide matching funds, and that can deter states from taking full advantage of those new options. But here they really address that up front and are essentially covering all or almost all of the state's costs to fund, I think, that all states will take advantage of this particular program. In addition, as Steve mentioned, unlike the Medicare provisions, the Medicaid payments can be used to fund upfront implementation costs of EHRs, as well as being used for the meaningful use incentives, which I'll talk about in a little bit more detail in a moment. So that's another key distinction and benefit. The only shortcoming that we see from the way that Congress structured this is that they set the bar pretty high in terms of the percentage of patients that particularly physician practices need to have. The physician practice would need to have 30% of their patients on Medicaid, which is a very, very high number. Even in a city like New York, where we have many Medicaid beneficiaries. So we're really expecting that those criteria will actually significantly limit the ability of physicians to participate in the Medicaid incentive program. And hopefully, if we can document that, Congress will consider relaxing those thresholds in the future. Go to the next slide. So here's how we've taken this framework of meaningful use and applied it to our particular statewide strategy to advance health information technology. On the left side, you see basically the language that is directly from the federal statute. And there are essentially three criteria that the physician or hospital is using an EHR, including electronic prescribing, that EHR is capable of supporting electronic exchange of health information, and finally that the EHR is able to supply and submit may be determined by the Department of Health and Human Services. On the right side, what you see is one of our graphical depictions of our overall framework for the interrelationship of frontline clinician uses of EHRs down to the use of the statewide health information network or the health information exchange infrastructure, which we are building across New York State, both on a statewide and a regional basis. And our view is that you really need to have an interrelationship of these three levels in order to assure the maximum value for the clinician's use of the EHR. And so we have the clinical informatics services layer, which really addresses data aggregation, reporting, and other kinds of services that help to translate the raw information that might be information, which then translates out to the clinician level through the EHR. So that's really just the depiction of our view of the interrelationship of those levels. And so we see these criteria as being both supportive of our strategy here in New York, but also clearly they are subject to further interpretation by the department. Next slide, please. So I think this is my last slide, and really what we wanted to convey here is that the left side picture is essentially the current state. And we will not advance meaningful use of EHRs utilizing this approach. First, it is very costly. Second, it results in great because it really doesn't advance interoperability, which is one of the requirements in the meaningful use criteria. And so, at least in New York, and hopefully at the national level, what we will see emerge is a picture that looks a little bit more like the one on the right. And essentially what the SHINY, or the Statewide Health Information Network of New York, is designed to do is help to reduce the number of individual interfaces that each EMR needs to support, to provide easier pathways to access this information using the Internet and using web-based protocols, and again to support the frontline use of clinicians connecting their EHRs to that network. And so this is our vision. This picture might look slightly different in other states, but we believe that this is a vision which is more and more supported by the healthcare stakeholders in this country, and that we really need to move from that left-hand picture to the right-hand, however we might want to label what exists in the middle. So I believe that's my last slide, and I will turn, oh, wait, I have one more. You want to go back? Okay, so just to summarize then, in terms of how we see the stimulus bill really translating into a very effective use in New York. We've got the meaningful use criteria, and as I said, the EHRs themselves cannot support this without a robust infrastructure for interoperability. In New York, we are building that infrastructure. We call it the Statewide Health Information Network for New York. It is based on a web-based set of protocols and services. The state-designated entity is the New York eHealth Collaborative, and we are ready to submit one of these implementation grants. And there are organizations like ours across the country now. In certain cases, it may be the state that will actually submit the grant application. And that grant application will, of course, include the statewide plan, which we basically already have in place. We just have to see how the specific criteria will be developed by the federal government. And then finally, that there are organizations which are specifically focused on supporting clinician-level EHR adoption. And in the legislation, they call these the regional extension centers. In New York, we already have some fledgling organizations that we call Community Health IT Adoption Collaboratives, or CHEETAs, that are working together in the framework of a service bureau, which is providing the same kind of soup-to-nuts support for EHR adoption at the clinician level that we envision. So that is my last slide, and thank you very much. I'll turn it back to Mark.
Thanks very much, Rachel, for that perfect discussion. John, can you walk us through what needs to be done from the perspective of standards and certification?
Oh, absolutely. And I certainly applaud everything Rachel has done with her team in New York, that architecture, that set of policies, and that implementation has worked extraordinarily well. In order for any region of the country to implement interoperability, you need two things. You need policy and you need technology. So policy, of course, who can see what data when, who are our trusted partners, what do we exchange, what are the state and federal laws that apply. And then technology, what are the data standards and architectures that we use to actually make this happen. So over the course of the last 3 years, I have worked in both these areas as chair, talking about the future. What will happen over this period of stimulus so that we get good policy guidance and we get standards and architecture. So if we go to slide 20, first, Federal Advisory Committee that is specified in the American Recovery and Reinvestment Act is called the HIT Policy Committee. Very aggressive timeline described in the Act. That policy committee will be named by April 3rd. So truly, we're about a week away from having the members of that committee named, and I know several folks who've been nominated for the committee don't have any insight into exactly who will sit on the committee, but that committee, when named, will make recommendations as to the prioritization of HIT infrastructure that is required, the standards and the certification criteria,
As you'll see, I do presume that HITSB will still be an effector arm working on standards harmonization, and that CCHIT will be a certification body. Now, the nature of the certification could change. It could be expanded to include such things as adherence to additional or different privacy constructs and policies or different kinds of data exchange or transport, but I believe CCHIT will still be that framework. So as stated in this act, this committee has to consider those privacy technologies and encryption technologies that are necessary to keep data confidential. It has to stipulate the nature of a nationwide health information network infrastructure. And important that I didn't say national health information network infrastructure. I mean, as Rachel said, this idea of creating regional health IT extension centers, cities, towns, regions, working together to create areas of interoperability, you imagine that that's going to happen, but then they may be interconnected so that either database centralized in the White House or one single kind of information exchange for the whole country, these sort of standards and architectures implemented locally that then interoperate across regions, states, and the country. Now, also, the policy committee has to consider not only clinical care, but also secondary use for population health, such as public health reporting and biosurveillance, clinical research, the consumer, these kinds of things. The policy committee, in effect, is like a board of directors that gives a set of priorities and marching orders to others involved in creating the actual technology and standards. The Standards Committee, next slide, is that body which actually then takes the policy committee recommendations and develops the very specific implementation guides. Those groups like the one in New York or Massachusetts, Indiana, others can now create this interoperability across regions. Now, I don't believe that the 20 people sitting on that HIT Standards Committee are actually going to be the one doing the bits and bytes and the very granular standards work. I believe they will be asking HITSB and its 600 member organizations to actually, through a public-private, open, transparent process, to deliver the very detailed specifications to them. Over the course of the next 90 days, you're going to see a vast number of deliverables. And although the American Recovery and Reinvestment Act doesn't stipulate a specific date that the Standards Committee has to be created, it does say that by the middle of May, it has to be hard at work on executing some of the requirements of the policy at the Office of the National Coordinator. I know that we truly have about 90 days to get a vast amount of this work done on making sure the standards are very specific and granular enough, that privacy protections are provided, and transport standards that are very, very tightly described are implemented. So let's go on to slide 22. So CCHIT, the Certification Commission for Health Information Technology, has been that body that's developed functional criteria to ensure that a software application is good enough. It has those functional characteristics and interfaces and interoperability for e-prescribing and labs that make it appropriate for use. Now, I've certainly looked over the course of the last couple of months and seen various comments in the press. It doesn't certify ease of use, or it doesn't certify quality measurement. The committee probably some additional recommendations and requirements for CCHIT to do additional certification. And Mark Levitt has said, and there was a press release yesterday, that CCHIT will absolutely accelerate its efforts, will be nimble, and will adopt as needed to meet the requirements of the stimulus bill, and will follow the guidance of the policy committee. Next slide. So on slide 23, I described the role of HITSB. HITSB has, over the course of the last 3 years, taken what are called use cases. These are breakthroughs suggested by the American health information community and created that standards harmonization guidance that would be necessary for a vendor, a health plan, a hospital to implement interoperability. Now, we've done this recognizing that we do want to reuse as much of these standards as possible across use cases, but we've done it without really focusing on any particular architecture. Well, I think now that we're actually in the implementation phase with many stakeholders, we're recognizing we need to get more specific. HITSP has, over the course of the last 3 months, worked quite hard to rethink about everything it's produced in the past and how to move that to a service-oriented architecture. So imagine this, that you're a vendor and you need to implement problem lists, medication lists, allergies, labs, and a discharge summary in a package that goes from a hospital to a primary care doc. Well, all you would need to do would be to go to an online tool, take a look at those particular data elements, get the XML constructs necessary to describe that content, and assemble a package, and send that using a set of web-based standards that include HTTPS, SOAP, REST, and appropriate security certificates. Faster for HITSP to harmonize and easier to maintain. So we are working quite hard on moving everything we have to a service-oriented architecture with highly reusable components. We will continue, I hope, to, over the next year, finish the work we have been chartered to do, so working with the National Quality Forum and its Health Information Technology Expert Panel and CMS, helping with what we'll call the minimum quality data sets. The stimulus bill specifies quality measurement in many, many places, but how do we ensure that there's a singular data set so that we can capture from every electronic health record or payer system the data elements necessary to measure quality. We've also been supporting the Social Security Administration and its efforts to streamline the whole disability process by electronic health record exchange without paper from hospital to the SSA. And we certainly do believe that, as Rachel described, these regional health IT extension centers hope that we will be a guidance. We will provide them with tools and interoperability specifications in their work as they build these local exchanges. Let's go to the next slide. And just one quick comment on our HITSP Quality Measures project. Quality is very, very hard to measure. And today at Beth Israel Deaconess, I ship data to 1,500 different organizations that want to ask about some aspects of our quality or the care we're delivering or our registry. So we really do hope that working with the National Quality Forum, the NCQA, and other organizations such as CMS, that we will come up with this minimum data set that starts meeting these needs, so that Rachel's diagram that shows point-to-point connectivity of hundreds of different organizations become a much more streamlined warehouses to support clinical care, going to public health entities, and going to those organizations like CMS that may have healthcare reform that pays for quality, not quantity of care. For my last slide, we've also been given a set of work by the Nationally Health Collaborative, the successor organization to the American Health Information Community, that rather than create a lot of new use cases for us in 2009, it's going back and filling in some gaps from previous use cases. We do have 2 new use cases, a newborn screening use case to take all the hundreds of newborn screening tests and codify them into part of the lifetime health record. And recognizing that clinical research and clinical trials are important, how do we take a clinician's record and with patient consent repurpose that if the patient should enroll in a clinical trial? We'll also work, and we'll be more nimble, so that as we get our directions from the policy committee and the standards committee, that we can really rapidly respond. I've been working very closely just today with all of the program managers of HITSP to really ensure we're responsive to all the demands of the American Recovery and Reinvestment Act. I think you'll see even over the next couple of weeks that we will begin accelerating all of our work and asking all of our volunteers to focus on all the deliverables that that act specifies between now and June 30th. So happy to answer questions. Let me turn it back to Mark.
Thank you, John, very much. That was a terrific presentation. We're going to now move to the Q&A. and we'll open up the lines in a moment. But before I do that, I want to remind everyone that the second event in this series is taking place next Thursday at 4 o'clock Eastern Time. Provider strategies for success, perspectives, and what providers should be thinking about as they analyze high-tech and plan on what to do. If you haven't already, please sign up today at www.gehealthcare.com, high-tech. And for your convenience, after the webinar closes, you'll be automatically directed to that site. And in the next few days as well, I know several of you have been asking for copies of the presentation. You'll find links to a recording of this presentation as well as a handout. And so we hope you'll be able to join us next Thursday. Now we're going to move to the Q&A, and we have a number of questions that have come in via email. And before we do that, operator, if you could explain how people can phone in their questions, we'll have time for a few of those as well.
Gladly. Thank you, sir. Ladies and gentlemen, if you would like to register for a question, please press the 1 followed by the 4 on your telephone keypad. If your question has been answered and you would like to withdraw your registration, please press 1-3. If you are using a speakerphone, we ask you to please pick up the handset before pressing your request.
Thank you. So our first question came in from email, and I'm going to address this to Rachel. There's an awful lot of talk that we're all hearing about meaningful use, and there's clearly more than just having the right product to be successful. What kind of resources do you expect to be out there to help providers be ready for meaningful use?
Well, as I hinted at in my presentation, I think that in addition to bolstering our view of the requirements for EHRs, and that's an effort which John Halamka's group, HITSP, and the CCHIT will be very important in terms of advancing the overall requirements for places organized in a better way to respond to those requirements. So that's a very important support right there. But it really has to go beyond that. And what we are doing and what the regional extension centers, I think, are conceived as doing is, in fact, being funding organizations to work at the community level to really take physician practices from the beginning to really the infinite end of successful EMR implementation, starting with readiness assessment and moving on to vendor contracting, product selection, workflow analysis, all of the essential ingredients to ensure that the implementation can be successful. And from our point of view, that support in some form or other can never end. It has to be ongoing. There has to be continuous resources to answer their questions. And then, as I indicated, that level of the clinical informatics services, and Dr. Halamka mentioned this as well, translating quality measures, translating public health measures, translating clinical research requirements into requirements that can be addressed directly through the EHRs, and then the focus of the interoperability between EHRs and health information exchanges is just an absolutely key support as well. And so that's why our view is that there is a strong interdependency between health information exchange, those informatics services, and the frontline support for EMR adoption in the physician practice.
Thank you very much. I'm going to do one more from email, and then we're going to open up the phone for a couple of questions. The question, and I'm going to direct this to Stephen Gorman, about it's a two-part. How is Medicare going to determine that a provider group is a meaningful user? And more specifically, in order to be eligible for Medicare bonuses, if people already have EHRs and already e-prescribing, will they still be eligible for those bonuses?
Yeah, I think I'll answer them in reverse order, Mark. For folks that are involved in program right now where there is incentives, whether it's for e-prescribing or participation in PQRI, If you are participating in a program like that, the expectation is that you would still be able to qualify for the programs that are outlined under the High-Tech Act. So if you're engaged today, I think the federal government is thrilled that that's happening and would like to see you. But the first part of the question, that might be a slightly more difficult one to answer. I think how exactly are the powers that be going to know that a customer is a meaningful user will be more clearly understood once the work that John and others are engaged with relative to defining meaningful use and defining quality measures. But I think at the highest level, you can expect a couple of things. Number one, you can expect that your physicians would be utilizing e-prescribing, which is something that is very easy to track back to the physicians and understand if they are using it. I think the second thing that everybody should anticipate is much like today with the PQRI program, there is an expectation that there would be information that physicians would be providing to Medicare on quality metrics and that they would be submit claims to Medicare, but on some frequency, whether that's quarterly or semi-annually, and again, that it could be tracked back to the physician and it could be demonstrated that these physicians are, in fact, participating in the program. So I think those are two givens, and then there'll be some additional specifics coming out as the rules are more clearly understood.
Thanks very much, Stephen. Operator, can we open it up to a couple of call-in questions, please? And if you can direct it to one of the speakers, or I'd be happy to if you're not sure who you'd like to have answer it.
Thank you, sir. We do have a question coming from the line of Kevin Dwyer. Please proceed with the question. Kevin, your line is now open. Please check your mute button and proceed with the question.
Yes, I'd like to say, and my question regards certification is there's language that talks about the electronic medical record must be certified. Can you elaborate on how that process is determined?
Yep. Hey, Kevin, great to hear your voice. I was wondering if there was more than one Kevin Dwyer in the world, but I'm glad to see it's you. Yeah, today, Kevin, it's really being controlled by that organization that John mentioned, the organization called CCHIT. And what they have done is they have a series of requirements that they measure electronic medical records against. They started in 2006. And what they do is each year that goes by, they have a set of requirements. Frankly, each year the requirements go up a little bit in terms of the capabilities. And software vendors out there in the community actually sit before a board of members of CCHIT. The software vendors actually demonstrate the capabilities of their product to this organization. If the organization feels that the vendor has the appropriate capabilities, then they deem the product to be certified, and then this organization will actually publish out on its website a listing of all of the products that are certified, and there's some question as to how long a certification will last, but currently the vendors are looking to keep pace with a certification requirement where effectively every other year they need to make sure that they have their products reviewed and are updated and are certified by CCHIT. That may move to annual as a result of the stimulus package, but that process has been in place for a while now that it has been tied to the stimulus dollars.
Thank you.
Thanks very much, Stephen.
Thank you.
Operator, we have time for one more question.
Excellent. And we do have a question coming from the line of Garrick Fields. Please proceed with the question.
Thank you. I was also inquiring about certification, and our practice is using, a very well-known GE product currently, and we've been using it since 1997. The question that I have, though, is, for other groups who have inquired about me about our use of centricity. Whoops, should have said that maybe. But having used that for a long period of time, and yet they still go to a different vendor, is the certification something other than something that is totally approved through the certification process of CCHIT?
Yeah, John, you may want to chime in as well, but it's my understanding that it is an all or nothing type of arrangement. So a medical group must be using a product that is certified. There are a significant number of products that are available in the industry that are certified. But if a product that is in use by a medical group or a hospital does not have the appropriate certification, or if that certification is not current with the guidelines, I do believe that the way the law is written right now, that would preclude the organization from being eligible for stimulus dollars. John, is that your understanding as well?
Well, this is correct. And so that the language is meaningful use of a certified electronic health record. Meaningful use will be further clarified by the end of 2009, December 31st, as the bill suggests. Certification, as I mentioned, I believe will be still done by CCHIT, and the CCHIT certification is pass-fail. You can't be 80% certified. But what we should watch for over the course of the next 90 days is there may be, some evolution of what is certified. That is, it may now include some additional interoperability components or privacy components or aspects of quality measurement, as the bill suggests. I still believe CCHIT will be the certification body, and it will be pass-fail.
Thank you very much. I appreciate that information.
Well, I'm afraid that's all the time we have for questions. There is additional on the GE website. So for additional information or to contact GE about the economic stimulus, please do go to the website www.gehealthcare.com/hightech. And you'll be directed to this page after today's webcast. And as well, as I indicated, in a few days there will be links to both the recording of today's webinar as well as a link to download the presentation. And we will be updating this resource frequently. As John indicated, there's an awful lot of work to happen in the next 30, 60, 90 days and throughout the year. So please check back frequently for the latest information on the economic stimulus plan. This concludes today's program. I want to thank all of our panelists and all of you for participating today. The second installment in the series will take place next Thursday, and we hope that you will be able to join us then. Thank you again.
Thank you. Ladies and gentlemen, that does conclude our call for today. We thank you for your participation and ask that you please disconnect your lines.